Good morning, everyone. Our topic is masquerades of angle closure. So, going through our case series, it is 36-year-old female presented with sudden onset of pain and blurring of vision in both eyes. Since one day, there was associated with headache and vomiting one episode. There was no other history, no history of flashes, or no history of trauma, and no history of fever or cough. And in past history, there was a history of frequent migraine attack 1 week back, for which she consulted a physician and was started on topiramate 25 mg OD for 6 days. And there was a history of family history of migraine. And on ocular examination, visual acuity was 1/60 in both eyes with no improvement with pinhole. And on ocular examination, the lids were edematous, conjunctiva and sclera congestion was there, and there is cornea, there is diffuse corneal edema, and the pupil were mid-dilated, and in AC there was 3+ cells, and peripheral iridocorneal touch was there. And 80 was 70 in right eye and 48 in left eye. Gonioscopy and fundus was hazy due to corneal edema. And we done a ASOCT and it showed the coleocaudal effusion in both eyes. And we done UBM and it also showed the coleocaudal effusion. And we had done the B scan and it showed the coleocaudal detachment. And another 44-year-old lady coming with complaints of foggy vision, headache, and with a history of topiramate intake 1 week before. Vision was 3/60 in both eye, 80 was 44 in right and 54 in left eye. The same scenario happened again, and AC was very shallow both eyes. And gonioscopy, the angles were closed, and we had done an optos photo and showed the coleocaudal detachment, and the ASOCT showed coleocaudal effusion, and B scan showed the same. And another 60-year-old male presented with pain and redness since 1 week, and there was a history of hypertension, diabetes, and cardiac CAD. And on examination, there was AC was shallow, and fine KPs was present on the corneal endothelium. And AC there was cells and flare, and people was briskly reacting, and the fundus showed the CD ratio of 0.8. And we asked for the drug history, but he told first time he is taking only medication for the diabetes, hypertension, and CAD. And we had done the ASOCT, it showed the coleocaudal effusion, and we had done the uveitic workup, it was normal, and FFA was done, it was normal. OCT macula was done, it showed a minimum macular edema only. So what we missed is this. We again asked the history, and he told that he consulted a dermatologist for contact dermatitis, and the dermatologist prescribed this. So here it is the topiramate. So we collected every case of topiramate induced angle closure last year, and with last year itself we got 8 cases, and all of them presented within 1 to 2 weeks after intake of topiramate, and 5 of them presented with coleocaudal effusion, and 4 of them presented with the caudal detachment. All of them improved after treatment with the cycloplegics and steroids. There was no patient ended with a non-resolving effusion. So what we got the inference is that bilateral angle closure with high IOP and severe AC reaction, and UBM and ASOCT showing ciliary effusion, and B scan showing CDs, we have to think of topiramate, and we have to ask for the history of topiramate. So what is topiramate? It's the oral sulfamide medication used for seizure, migraine, neuropathic pain. Incidence is very low. It is 3 out of 1 lakh patients. And acute angle closure glaucoma report suggests that majority of cases occur within first 2 weeks of the initiation of treatment. How will we go for the treatment? Early diagnosis and recognition and discontinuation of the offending agent is very important, and we have to start with topical and oral anti-glaucoma medications. Acute suppressants can be used, and cycloplegic agents such as atropine and cyclopentolate can be used, and topical steroids, systemic steroids have to be used. And there is strict no to prostaglandins and miotics, no role for laser PI, and there is no role for laser iridoplasty. And if there is no non-resolving effusion and if there is lenticular corneal touch, we can go for the surgical approach, choroidal drainage procedures. And the overall prognosis is very good. Good prognosis, the medication is stopped early. And other details we have to be kept in mind is the VKH. What is against the VKH is, in VKH we can see the neurological or cutaneous abnormalities, and in VKH there will be diffuse granulomatous KPs, and there will be blurring of optic margin, and there will be in FFA it will be disc lake, but in topiramate the FFA will be normal. Another DD we have to be kept in mind is posterior scleritis. It is also associated with the optic disc edema, and B scan there will be T sign. FFA there will be disc leakage. Another thing we have to be kept in our mind is Baton body. That is if the patient is starting on the oral antibiotic, that is amoxiclav, our third person has started on amoxiclav, so we have to ask for this also. And the studies has shown that the moxifloxacin eye drops is also cause the Batten-Bardy syndrome. So what is Batten-Bardy? That is bilateral acute iris transformation and bilateral acute iris depigmentation. That is, this pigment will deposit in the trabecular meshwork and occlude the trabecular meshwork, and it will increase the IOP. So what is our conclusion is that ocular complication from topiramate therapy appears to be rare, but with the growing popularity of the medication and frequent off-label use, it is important to create awareness among patients and healthcare providers of this drug-induced sequelae. So communication and teamwork is necessary in this scenario. Thank you.
Is there any reason why you did both UBM and ASOCT in these patients?
There is no reason, sir. We have to confirm the diagnosis for that. We had done the UBM also. But in our center, the UBM is not so clear. So we are depending upon more on ASOCT nowadays.
Okay. In general, if you're looking at anything that is posterior to the ciliary body or posterior to the iris, the UBM is a better option. You don't really need to do both.
Yes.
The second is just a comment. In one of the slides, you showed the prescription with the patient's name on it.
Okay.
You should mask the name. It should not be there.
Okay, sir. Okay, sir.